Okay, moving on for our final talk for the afternoon. I'm really pleased to have Professor Richard Hillman joining us now. He's joining from Sydney, so he has a bit of a time advantage, which is good. But Richard is a sexual health physician with special interest in anal HPV infection. He's a current president of the International Anal Society and led the development of the international guidelines for the practice of high-resolution anoscopy and digital and rectal examinations, or DARE. He was the Australian Chief Clinical Investigator for the male Gardasil studies and for SPANK, a large study investigating the natural history of anal HPV infections. He now runs the Dysplasia and Anal Cancer Service at St. Vincent's Hospital in Sydney, and only one of two clinics specifically dedicated to anal cancer and pre-cancer diagnosis and treatment in Australia. He's currently evaluating the role of high-resolution anoscopy in the follow-up of anal cancer cases and the use of novel therapeutic agents in treating anal pre-cancers. So I welcome Associate Professor Richard Hillman to talk about anal cancer screening. I think it's a very important topic, especially as we have an aging HIV population in New Zealand, and it's something we should talk a lot about. Thank you, Richard.
Thank you, Mark, and thank you for inviting me to join this really important meeting. I'm sad that I can't come along and join you in person. I love New Zealand, and I hope to come back and meet you all guys in the not too distant future once we've got this wretched virus under control. So I'd like to now start sharing my screen. Hopefully we'll get the technology working. Here we go. Okay. All right, so can you see that screen okay now? Great. Okay, so I will get started. Thank you for inviting me to this talk. I'll start by mentioning my disclosures, none of which I think are terribly relevant to this particular presentation. Now, my presentation is very different from Miguel's. It's going to be more hands-on in terms of what you can do with your butt and how you can hopefully prevent or treat anal cancer most effectively. So I'm divided into four components. Firstly, what is anal cancer for those of you who are not familiar with it? Are you at risk? And I'll take you through a case study of a person we saw fairly recently, and then finish by giving you some hints and ideas about how you can take this forwards. So firstly, what is anal cancer? I describe it as the most stigmatized condition of all. It's about cancer. Nobody likes talking about cancer. It's the anus, and everyone's hung up about their anus. It's about defecation, sometimes it's about anal sex, and it disproportionately affects certain at-risk groups who are themselves stigmatized. And as one of my patients recently told me, who'd lived through HIV in the 1980s, he said, look, Richard, it's like HIV was in the 1980s in terms of the stigma associated with anal cancer. Many of my patients don't talk about the fact they've got anal cancer, well, they say bowel cancer, because that is somehow more acceptable to their friends and relatives. So anal cancers, all anal cancers can easily be felt if you actually look in the right area. Now, unsurprisingly, you find anal cancers in the anus. And about 90% of them are actually inside the anus and about 10% on the outside. All of them can be reached with a finger. And that is really one of the key messages I want people to understand, is that anal cancers can easily be felt not only by clinicians, but also potentially by person who owns the anus. So in terms of symptoms of anal cancer, the tragedy at the moment is that everyone presents late with anal cancer. So that everyone presents with symptoms. Typically, this is a paper from Melbourne. They've been present for 3 months. The most common symptom is fresh rectal bleeding, often associated with some pain, altered bowel habit. People are often aware of a lump, mainly externally, but also internally if they're doing an internal examination. A small proportion of people report tenesmus. And what tenesmus is when you go to the bathroom to empty your bowels, you don't feel as though you fully empty your bowels. And I think that the fact that this is a relatively low proportion of people tells us that the anus has a capacity to absorb growing quite a big lump without actually causing any symptoms. And therein lies one of the problems. At the moment, less than 5% of anal cancer, newly diagnosed anal cancers, have no symptoms. So there's plenty of opportunity there for us to make that a much higher proportion with no symptoms of people who are predicted, identified on screening. So how common is anal cancer? Now, the most recent data I could get hold of from New Zealand were these, which showed about 60 to 70 cases per year. And interesting, you'll notice here that women have more anal cancers than men. And we'll come back to that in a second. However, within the men, MSMs, in particular HIV positive MSMs, are disproportionately represented. So my clinical practice includes both men and women. Because of where I am in Darlinghurst, it's predominantly HIV positive gay men, but I'm seeing an increasing proportion of women coming through with anal cancer. And if you look here at the second highlighted box, you'll see that it predominantly affects those people over the age of 45. And I think people under the age of 45 are pretty low risk of anal cancer. And I don't think we should get too wound up about screening younger age groups, but certainly 45 years and onwards, we need to start seriously thinking about how we can identify these cases much sooner. And you can see from the columns on the right-hand side, it's throughout the country. These are again New Zealand data showing the annual incidence rates by age. Firstly, you notice that the female rates are higher than the male rates. And again, it really starts taking off around the 45 age group. And for interest, I've given you the age standardized cervical cancer rate in New Zealand of about 7 per 100,000. So that gives you a ballpark idea of what sort of condition we're dealing with and how screening potentially might be quite an important response to this particular condition. Okay, so sorry, I'm going to jump to Australian data here because the numbers of cases in New Zealand I don't think allow us to get good quality data. These are the rates over time. So you can see for both women and men, the rate has slowly increased per year. So we're seeing it presenting more frequently. We can talk about why that may be later on. So in summary, anal cancer is pretty uncommon. It's globally very rare, maybe 30,000 cases per year. We see maybe 600 cases per year, about 100 deaths. And the age standardized rate for anal cancer in Australia is about 1.7. And the consequence of that is there's little awareness of anal cancer, not just in the general community, but also amongst most healthcare professionals. They simply have not had to deal with the case of anal cancer, and that causes problems, I think. If you compare cancer of the anus with the colon or breast or prostate, that I think emphasizes that anal cancer is a relatively uncommon condition. And you can understand why colorectal surgeons, for example, are very much focused on colon cancer rather than anal cancer. Colon cancer is a completely different condition. It presents differently. It has different demography, different epidemiology, different treatments. It's produced by a different set of events. Now, this is probably going to be my most complicated graph here, so just please bear with me. On the vertical axis here, we've got the anal cancer incidence per 100,000 person years, and various categories of people in the community. And the general population here, HIV negative, non-MSMs, and all HIV negative women have a rate of about 1 to 2 cases per 100,000 population. Now, if you look at HIV positive gay men, you will see there's a dramatically higher rate. It's typically 50 to 100 times higher rates in gay men living with HIV. And it's particularly problematic for people over the age of 60. And really the rates are really quite substantially high from 30 onwards compared to a low baseline rate. So I think that's one of the key messages of this presentation is that if you're living with HIV and you're a gay man, you are 50 to 100 times increased risk of anal cancer compared to the background community. If you look at other populations, this group of people here, the people who do not identify as, again, bisexual men who are male, you can see they have an elevated risk of anal cancer as well, about 20-fold increased risk. And women who are HIV positive also have an increased risk of anal cancer. And again, it's clearly related to age. And finally, I thought I'd just flag HIV negative gay men, who, of course, there are many more HIV negative gay men than there are HIV positive gay men. So in terms of total numbers of cases, they actually form a substantial group of my clinical practice. They have an elevated risk here, about 10 times the risk of the background community. The quality of data are not great on that because of some methodological problems, but essentially even HIV negative men who have sex with men are at substantially increased risk of anal cancer. So let's translate that back to a slide I showed earlier in terms of, remember, the anal cancer is about 1.7 cases per 100,000. Women living with HIV have got approximately the same rate as colon cancer in the general population, and gay men living with HIV over the age of 60 have got about a similar rate of anal cancer as they have of prostate cancer. So I think that's I find a really useful peg to hang on people's concept of risk. So your risk of anal cancer is substantial, because as we know, as men, prostate cancer is our #1 cancer. If you're a gay man with HIV, your risk of anal cancer is about the same as your risk of prostate cancer is. So bringing all this together, why do some people develop anal cancer? I've already mentioned that women are more likely to develop it than men, and that's probably because women acquire HPV, wart virus, through their vagina, and then it gets spread to the anal canal, either through passive transfer or through receptive anal sex. As we get older, our risk of many cancers increase, including anal cancer. Having receptive anal sex helps in terms of transmission of the virus, but it's by no means essential. I have many patients who are lifelong TOPs who develop anal cancer. It seems to be the total number of lifetime sexual partners, which seem to be a significant risk factor. Smoking is also a factor as well. Now, living with HIV obviously impacts on one's immunity. The key identifiers in terms of what makes you particularly at risk is a low CD4 nadir. So if your CD4 has dropped, say, to 200, 100 in the dim and distant past, and you've lived with an impaired immune system for many years, this potentially drives the process which ultimately can lead to cancer. But undoubtedly, this factor, which we don't really understand at the moment, is significant. Some people just have got bad luck, and they'll have a completely ordinary life, and then they'll just come down with the most appalling conditions. And we think that our ability to handle the underlying virus varies enormously, just like it does with HIV. So the genetics, we're only beginning to get a handle on how to predict who will get a problem and who will not. All these factors act through acquisition and maintenance of infection by certain strains of wart virus, so-called high-risk HPV. And so anal cancer develops by a normal anus, physical contact, particularly sex. You acquire certain strains of wart virus, particularly type 16, and over years, that leads to an irritation, if you like, of the lining of the anal canal, which we call high-grade or HSIL, or AIN2, AIN3, you may have heard those terms. And then over years, in a minority of people, does the AIN3 progress to cancer. And this is really exactly the same as how cervical cancer develops. It just happens to be a different orifice. There are many similarities between cervical cancer and anal cancer, and indeed we draw a lot of benefit from looking at the research on the cervix. And just to mention, this is where Gardasil works here. It essentially prevents the initial acquisition of HPV, and it's really, really important that people get the Gardasil before the onset of sexual activity, because once you pick up the virus, Gardasil is no good at getting rid of it. So please, you guys have done great work in getting your school kids vaccinated with Gardasil. Please, it's really important that that continues. Okay, so with that background, I'd like to take you through John's case study. So I first met John a few years ago now, at which point he was a 44-year-old gay man diagnosed with HIV in 1995 with a CD4 nadir of about 200. Now, for someone diagnosed then, that's not terribly low CD4. His current CD4 is reasonably well maintained at 600, getting on with life, no anal symptoms, generally very well, no intercurrent infections at all. And he happened to come for a routine HIV clinic attendance. And at that time, I had a study called BASIL, blokes with anal squamous intraepithelial lesions, and we did an anal swab test from him. And we looked for abnormal cells. And he was flagged because he had some abnormal cells suggestive of a high-grade lesion. So the next stage for John was to do a digitoanal rectal examination. And essentially what this is using a gloved, lubricated finger gently applied to the anal sphincter until the anal sphincter relaxes. And then we slowly insert the index finger, using the pulp of the index finger, which is highly sensitive to touch, and slide it through the anal canal, putting some gentle lateral pressure on. And then we insert it all the way through to the rectal space. And you can feel the anal canal is essentially a sling of muscles. And once you're through those sling of muscles, you can actually feel it give. And then you know you're in the rectum. So you know at that point, you've tested the whole length of the anal canal. And then essentially you slowly partially withdraw and repeat that through whole 360 degrees. And then you end up by palpating, by examining the external surface wall, because as I say, 5-10% of cancers actually hide underneath the surface of the skin on the outside. So digital anal rectal examination is something that you can do to yourself, or properly trained clinicians can also do it and can pick up a cancer about 3 millimeters or above. Now, people get worried, both clinicians and patients get worried about doing a digital anal rectal examination because they're concerned they might miss something. To which my response is, you may miss a cancer if you do a DARE, but you will miss a cancer if you do not do a DARE. So it's a matter of balancing the risk. And there's now published evidence that people living with HIV who are properly trained can detect cancers 3 millimeters and beyond. Now, if you get a cancer that small, the chance of survival once diagnosed is 100%. So this is a really important piece of information which I want to get across. If we get this, the earlier we get the cancer, the better the outcome. Self-DAREs are possible, but you do need to be properly trained. And the analogy I use with this is a breast self-examination. Many women now do self-examination of breasts and check for lumps, and that's undoubtedly saved lives. So what do we do about that? Well, that's quite a contentious issue. There are a number of chemical treatments, particularly for use on the outside if we diagnose high grade on the outside. Many of my colleagues in the US and Europe, and indeed in WA, we use physical destructive methods, and I've listed some of them there. But when we did a literature review, we were very concerned that they had high rates of occurrence, particularly in the HIV positive community. Poor compliance is a pretty unpleasant treatment. You need multiple treatments. You can have 60 to 70% recurrence rates despite very good treatment. And so we adopted a watchful waiting approach. And we feel that about 5% of high grades will need treating. And we're currently about to start a study trying to confirm some findings from Holland that there are some specific what are called methylation markers within biopsies, which will tell us that that high grade's about to flip over to cancer. So watch this space on that stuff. So how do we treat, John? Well, the most important recent development of treatment of anal cancer is something called VMAT, or volume modulated arc therapy. And essentially what this is a highly specialized piece of software which allows the radiotherapist to target just the cancer. The three pictures here are meant to represent the different ways in which you can target the cancer. The cancer is the red thing in the middle, and the yellowy green colors are the beams of radiotherapy. This is the standard radiotherapy. This is called IMRT, which is often still used, and this is VMAT. And essentially what the software does, it allows you to minimize the collateral damage. The problem with treatment of radiotherapy of the anal canal is deep inside your pelvis, and so people in the olden days used to get terrible burning of the skin, the vagina, the penile skin, and so forth. But with VMAT, it allows you highly targeted radiotherapy, minimizing the burns. And I've got some legacy patients now, had standard radiotherapy and had the most appalling burns and continue to suffer from that. So please, please, please make sure that you guys do VMAT, or at the very least IMRT, to minimize that side effect. Chemotherapy has a role to play in the treatment of anal cancer, but it's very much a subordinate role. It just essentially radiosensitizes, and it's a relatively straightforward and uncontroversial thing. And yes, you get a little bit sick when you have it, but it has no long-term sequelae. Okay, so what can we do now? One of the things which gets me up every morning is my anger that deaths from anal cancer are entirely preventable with existing technology. We don't need to wait. Early diagnosis can save lives. People living with HIV, particularly gay and bisexual men, need to be aware of this condition because the risk is very substantial. Stigma causes the deaths of people. Don't become a victim of stigma. Learn about your anus. Be aware of any change in anal symptoms. Talk about your anal health. Trust me, clinicians don't like talking about anuses. They really don't. When patients finally come to me, they kind of talk forever about their anus because they feel able to talk about their anus. You just need to educate your clinicians, I think, to become a little bit less uncomfortable about talking anus. We've all got an anus, and we shouldn't be ashamed of that. Gardasil is unlikely to be of value. There are some rare cases where we do recommend it, but I wouldn't waste your $500 on it unless there's some very specific indications. As I say, raise the issue with your clinicians. We know that clinicians often forget. They get so wrapped up in all the other aspects of HIV care, they often forget about the anus. Dare to dare. Ask your clinician for a dare. Make sure you have your regular bowel cancer screening tests. Now, this looks for bowel cancer, it doesn't look for anal cancer, but it will pick up the occasional anal cancer as well. And if you have a colonoscopy because of a positive bowel cancer test, make sure that they retroflex. As I've already mentioned to you, I don't know what happens in your major centers here, but I would certainly want VMAT, because if you don't get VMAT, then you're going to have lifelong problems from burning. Anal cancer rates in people living with men, particularly men living with HIV, are about 4 times what the rates of cervical cancer were before the introduction of screening. So I think it's absolute tragedy that we don't do screening on very specific populations. We're doing a number of screening trials at the moment, and essentially what it is having an anal swab, maybe self-collected, and we're piloting that at the moment. And then depending on the results of the swabs, a minority will get referred on to high-resolution anoscopy, and a minority of those will undergo treatment. Unfortunately, what this involves is significant investment in infrastructure, and that's the key stumbling block. It takes a while to train up to do the procedure of high-resolution anoscopy. We've now got online training. This should make it a bit easier, but it involves substantial training and investment. What can you do now? You can reduce your risk, make sure your CD4 counts are maintained, stop smoking, keep your physiological age as low as you can do. We've all got problems with our chronological age as it goes up, but the things we can do to keep our physiological age as low as possible, and that's diet and exercise, all the motherhood and apple pie things. Be gentle with your anus. Don't scratch it too much with toilet paper. Avoid soaps and detergents. And condoms, I know they're terribly out of fashion now, but PrEP, unfortunately, whilst it's fantastic at preventing transmission of HIV, it does nothing for HPV, and I have a worry in the population who have not been vaccinated, that we're going to have a substantial increase in HPV-associated anal conditions in the years to come. So at that point, I'd like to say thank you for a very brief romp through the anus. And those are my contact details. If you search for anal cancer St. Vincent's, you'll find a whole host of resources linked to that, many of which were developed with the input from our local body positive. So I'm very grateful to them. And don't forget, March 21st in 2021 is Anal Cancer Awareness Day. So I want you all out there with your peaches protesting loudly for screening. Thank you.
Okay, thank you. Thank you, Richard. That was a very informative. I've seen you present in Australia, and I've always been very impressed at how simple you make this and how engaging in terms of people talking about their anuses. I think it's a very good thing. Just to reiterate that people are able to do their own dares, and I know Positive Living New South Wales, I think, has created resources for people to be able to do that themselves or with their partner to do those self-examinations. And I think that's a really good way for people to do some self-monitoring and to raise those issues with their doctors, but also being able to have those conversations with their doctors is really important as well.
And get to know your own anus. I mean, it's not going to bite you. You know, it's just a part of your body. Plenty of lube, obviously, gentle relaxation. Get to know part of your body, and the key thing is any change. You know.
Yeah. So somebody's asked, in terms of arsplay and anal cancer, is there stats on that? But I presume arsplay is basically going to be covered off by all the things in terms of contact and transmission and things like that as well.
Arsplay, did you say?
Arsplay, yes.
Look, the quality of the data is not very good because, oddly enough, many people don't disclose what they get up to when they go to see their clinicians. What I can tell you, as I emphasized right at the beginning, just because you're a lifelong top doesn't mean you can't get anal cancer. HPV is a bugger of a virus. It spreads very quickly, and rimming, we know, will transmit it. HPV can be found on the fingernails, and the closest association with number of sexual partners, because presumably that exposes you to a wider range of HPV genotypes. Unfortunately, people living with HIV have got a wider range of HPV genotypes causing cancer than people who are not living with HIV. I mentioned type 16, that's 70–80% of or maybe up to 90% of anal cancers. But people living with HIV have got a few other types of HPV which can also cause cancers. So arsplay, it's always a balance of risk, really, isn't it? And the benefit of arsplay is you will find a cancer if you know what you're doing. Yeah. So I would almost encourage it, Mark, if you don't mind me saying so.
So just with the Gardasil being rolled out, I know that's I think it's 27, I think is the age group for males in New Zealand. And I think it might be the same for females. Theoretically, that would lead to an eradication of anal cancer going forward with that age group?
I'll be out of a job in 50 years' time. That is true. So the trouble is, once the HPV has been acquired, so at the moment you will find everybody over the age of about 25 or whatever it is has not been vaccinated. And with the median age in the late 50s, early 60s, we've got a cohort of, for the next 30, 40 years of people coming through who I think we need to do something about. Yes. With 100% vaccination of both men and women, then we won't need a screening program. But that's true of cervical cancer as well. Yeah, okay. So in the future we have promise. One question is, how do you learn to do high-resolution anoscopy? That's from... Okay, so we now have an online course which teaches you the theoretical basis and some of the practical aspects of HRA. It's a 12-module course we've now developed, which is available through the organization, IANS, International Anal Neoplasia Society. And then on top of that, what we do is we get mentorship of clinicians, which I do here in the department. The trouble is it's not something that can easily be simulated remotely, so you really need to be able to grab the machine and learn how to handle it. It's a bit like riding a bike. You can watch videos, but it doesn't quite match the reality of the world. So you do need some deliberate mentorship. Okay.
That's been really informative. I think it's going to spark a lot of interest in DARE and anal cancer and self-examinations. I think that will be a really good topic for people to bring up and to travel further with. So I thank you for presenting that information in a very easy to understand manner, and for all your work in this area as well. I think that's been really informative. Thank you.
Well, thank you for asking me to join you. I much appreciate it.
Thank you.